Today we will discuss about the hereditary hyperbilirubinemia. So that is a very important for the USMLE and for the MBBS students. So let's discuss. Before discussing the hereditary bilirubinemia, first we will discuss about the bilirubin metabolism. So this bilirubin is produced by the hemolysis of the RBC. So these RBC release heme, and this heme is then is captured by the macrophages, and in the macrophages this heme is converted into the unconjugated bilirubin. So this unconjugated bilirubin then is come in the blood, and it is taken by the albumin protein, and this albumin protein take this unconjugated bilirubin from blood to the liver. So what happened in the liver? This unconjugated bilirubin is converted into the conjugated bilirubin by enzyme UDP glucuronosyl transferase. This enzyme is very important because this enzyme is absent or decrease in hereditary hyperbilirubinemias. We will discuss these hereditary hyperbilirubinemia in detail. So after the conjugation of the bilirubin in the liver, this bilirubin becomes the component of the bile. So this bile that is produced by the liver, it is then secreted into the hepatic ducts. Then through this hepatic duct it comes into the gallbladder. So what gallbladder do? So gallbladder concentrated and store the bile. So concentrated and store the bile. So when the food comes into this duodenum, intestine, what happens? The enzyme CCK, this CCK is released, and this chemical CCK causes contraction of the gallbladder, and this contraction will release this concentrated stored bile into the duodenum, right? So when the bile comes in the duodenum, it converts into the urobilin by gut bacteria. So this urobilin 80% excreted in a feces as stercobilin. This stercobilin gives the brown color of the stool, right? So if this urobilin absent, then the stool has a clay colored. That means the bile flow is obstructed, right? So this urobilinogen, the remaining 20%, of this urobilinogen, 90% is captured by the liver through the enterohepatic circulation, and 10% goes into the kidney and excreted as a urobilin, giving the yellow color of the urine, right? Okay, so this is again the same concept. The bile is produced in the liver, then this bile is excreted into the hepatic duct, then stored in the gallbladder, then it will released into the duodenum, right? So the duodenum, then it will goes into the feces and the urine, and some portion is captured by the liver through enterohepatic circulation, right? So again, this is the repetition of the previous concept. So unconjugated bilirubin in the blood, right? Then it goes into the liver. This is the liver cells. So what happened? Liver conjugated this unconjugated bilirubin. Here is the two hereditary hyperbilirubinemia. One is Gilbert, other is a Crigler-Najjar. So Crigler-Najjar syndrome. So in Gilbert, this enzyme UDP glucuronosyl transferase is decreased, right? While in Crigler-Najjar is absent or severely decreased, right? So Crigler-Najjar is severe disorder, right? So after this unconjugated bilirubin is conjugated by this enzyme. It is converted into the unconjugated bilirubin. Then it is excreted into the bile canalicular lumen. So there are two another hereditary hyperbilirubinemias known as a Dubin-Johnson syndrome, Dubin-Johnson, and Rotor syndrome. So they are basically the disorder of the excretion of the conjugated bilirubin. So these two disorders, they lead to unconjugated hyperbilirubinemia or indirect hyperbilirubinemia, while these two, Dubin-Johnson and Rotor, they lead to conjugated hyperbilirubinemia. I hope this makes some sense. Okay, so when we suspect the patient the hereditary hyperbilirubinemia, the first thing we do LFT. So we check the isolated hyperbilirubinemia. If there is a direct hyperbilirubinemia, we suspect Dubin-Johnson and Rotor syndrome. And if there is an indirect, then it will be due to the hemolysis, Gilbert, Crigler-Najjar, and neonatal. So neonatal is a two things. It may be physiologic and pathologic jaundice. So these are very high yield concept. If jaundice appear less than 1 day in the neonate, it will be the pathological. If it appear after 1 day, then it will be physiologic, right? So physiological jaundice will resolve in term is 1 week. In non-term patients, children, it will solve in 2 weeks, right? So if the isolated hyperbilirubinemia is not present, then we'll check AST, ALT, and alkaline phosphatase. So first condition, if AST and ALT are more than alkaline phosphatase, then this will be the hepatocellular pattern, and it may be due to the many liver injuries like hepatitis, cirrhosis. So another condition, if alkaline phosphatase is more than AST and ALT, it will be the cholestatic pattern, and the cause will be the gallstone, pancreatic mass, and intrahepatic cholestasis. Okay, so bile. So bile is basically produced in the liver, hepatocytes, stored and concentrated in the gallbladder, excreted into the duodenum after meals, cholecystokine, gallbladder contraction. So bile salts plus glycine and taurine are essential for the lipid digestion. Fat soluble vitamins like A, D, E, K. So bilirubin and bile, major route of the bilirubin excretion from the body, conjugated in the liver by UGT, excreted in the bile. So bilirubin is basically the breakdown product of the heme, released by old RBCs, macrophages engulf residual heme, converted to bilirubin. So bilirubin conjugation. So bilirubin conjugation basically there are two types of the bilirubin. Is a conjugated bilirubin that is derived from the heme. It's a poor soluble in the water, and it may deposit in the brain and may lead to kernicterus. Why it deposit in the brain? Because this unconjugated bilirubin is a lipid soluble, and this bound to the albumin. Conjugated bilirubin made in the liver by the enzyme glucuronic acid conjugated to the bilirubin increase water solubility and excreted in urine. When the patient has a conjugated hyperbilirubinemia, the urine of this patient is a dark urine. Why? Because of increased conjugated bilirubin in the urine. So the first hereditary hyperbilirubinemia, all the hereditary hyperbilirubinemias are autosomal recessive. This is a high yield stuff. So Gilbert syndrome. So the Gilbert syndrome, UDP glucuronyl-transferase enzyme is mildly decreased. The patient typically asymptomatic or mild jaundice, usually with the stress, illness or fasting, even menstrual blood loss, even febrile illness may lead to the mild jaundice in the Gilbert syndrome. Increased unconjugated bilirubin without avoid hemolysis, relatively common benign condition. So Crigler-Najjar syndrome has a two high yield types, type 1 and type 2. So the type 2 is less severe and respond to the phenobarbital, which increase the liver enzyme synthesis. So type 1, the UDP-gluconosyl transferase is absent or severely decreased, present in the early life, but some patient may not have the neurological signs. Finding the jaundice connectus, because this unconjugated bilirubin is a lipid soluble and it can cross the blood-brain barrier and it will lead to the connectus. Increase unconjugated bilirubin. So the treatment is a plasmapheresis and phototherapy. This plasmapheresis and phototherapy does not conjugate the unconjugated bilirubin, but it increases the polarity and it will lead to the increased water solubility to allow excretion. So liver transplant is a curative in case of the Crigler-Najjar type 1. So now the Dubin-Johnson syndrome, the Dubin-Johnson and Rotor syndrome are basically the excretion defect of the conjugated bilirubin. So the difference through the Rotor syndrome, in Rotor syndrome, no dark liver, right? While in Dubin-Johnson syndrome, the dark liver, right? So how I remember this, because the Dubin-Johnson is a D. So D remind me the dark liver, so that is a very high yield. So Dubin-Johnson is basically the conjugated hyperbilirubinemia due to the defective liver excretion, right? So the last one is the Rotor syndrome. So the Rotor syndrome is a phenotypically similar to the Dubin-Johnson syndrome, but it's milder presentation without black regular liver due to the impaired